from the platform of This is the 95th webinar from the platform of the Pakistan Medical Association. We hold it in collaboration with the medical colleges, which are Women Medical College and the Azad Jammu Kashmir Medical College, and in collaboration with the Pakistan Physiological Society, the Southern Asian Association of Physiologists, of which Dr. Kaushik is a member, and as well as the Pakistan Association of Pathologists. But basically, it is the Pakistan Medical Association's platform. And on this 95th webinar, we have a very, very academically sound speaker who is our professor of medicine at Women Medical College, and he works in the district headquarter hospital of Abbottabad. The topic that we are going to discuss today is the Crimean-Congo Haemorrhagic Fever, CCHF. And before we start, I would request Professor Masood Saab for the recitation of the Holy Quran. Over to you, Professor Masood Saab.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد صدق الله العظيم.
Jazakallah khair. Now we give it over to Professor Mir Jalaluddin Saab. And everybody else can mute their mics.
Assalamu
Dr.
alaikum.
Wa alaikum assalam.
Can you hear me all?
Yes, loud and clear.
I'm very grateful to Professor Salma and Pakistan Medical Association to give me a chance to speak in front of such an eminent group of people. I was going through the invite, and I'm very astonished to read that this is the 95th webinar of such kind. Pakistan Medical Association is doing a great job in constantly arranging such webinars on different topics or different specialities. Over the next 40 to 45 minutes, I'll be talking to you about Crimean-Congo Haemorrhagic Fever. My name is Dr. Mir Jalal, and I'm working as a professor of medicine at Women Medical College, Abbottabad. The Crimean-Congo Haemorrhagic Fever, or shortly, which is known as Congo fever, it came into news, and it was talk of the town last month when a colleague, our colleague, a doctor working at Quetta, he died while being shifted from Quetta to Karachi. He got the disease while he was operating upon a patient which was later diagnosed as Congo fever. And after that, subsequently, 11th healthcare workers of the same hospital, probably it was Sindaman Hospital in Quetta, they also contracted the disease. Later on, last part of the previous month in the November, 11 more cases were diagnosed in Karachi. So the Congo was very much in news last month. Crimean-Congo Haemorrhagic Fever is a zoonotic disease. It is transmitted by ticks. It was first described in Soviet soldiers in Crimea in 1944 and was named as Crimean fever. In 1956, the virus was isolated from a child in Congo with similar symptoms and was named as Congo fever, and the virus was named as Congo virus. The causative agent was shown to be the same in about 1964, and it was in 1969 it was named as Crimean-Congo Haemorrhagic Fever. Crimea is a peninsula in Eastern Europe. It is surrounded by Black Sea, and this was the place where the disease was first diagnosed. This is the geographical distribution of Crimean-Congo Haemorrhagic Fever. It is endemic in parts of Africa, Middle East, Asia, and Southeastern Europe. It has been observed in over 30 countries now. This orange part where the Pakistan also lies, and these orange parts of the world are those areas where about 50 cases of Crimean-Congo hemorrhagic fever are diagnosed each year. The red part, which comprises of Iran, Turkey, and Afghanistan, in these parts of the world, the incidence of Congo fever is even more, and more than 50% of cases, more than 50 cases are diagnosed each year. Uh, Congo fever is endemic in Pakistan with sporadic outbreaks. The first ever case of Crimean Congo hemorrhagic fever was reported from Rawalpindi General Hospital in 1976 when a CCHF patient was had a laparotomy, and then subsequently 12 or 13 healthcare workers in that very hospital, they go on to develop the disease, and that led to death of three people in that hospital. Since then, there are sporadic breaks in the country. The NIH, which is responsible to keep the data of these diseases, its report uh, showed that from January 14 to May 2020, the number of cases verified nationwide were about 356 with about a 25% fatality rate. Most of the cases were reported from Balochistan and then Punjab and Khyber Pakhtunkhwa and some parts of the Sindh. The incidence of this disease peaks in June and October, but cases go on to develop throughout the year. Exposure of bulk of cases were traced back to animals in Quetta, Zob, Kila Safula, Pishin, and Loralai districts of Balochistan. Balochistan is the main place where the cases are reported each year. Similarly, a number of patients are diagnosed in Karachi, Rawalpindi, Multan, DI Khan, Mansehr, and Abbottabad. In Abbottabad, when we were doing training in general medicine, we had an outbreak in AU Medical Hospital where some of the doctors also contracted the disease, and one of the doctors died from the same disease. There is always a history of contact with the patients or with slaughtering animals. Imported cases from Afghanistan are also continuously being reported to major hospitals of Quetta, Peshawar, and Islamabad throughout the year. This is interesting that there is a of fever. It has got biannual peaks between March and May, and then between August and October. So there is a peak in fall and spring season. Peaks of the disease is associated with life cycle of ticks, exposure to migrating animals, and human contact with vireming animals during slaughter and ticks during handling. These pictures are from our famous Chinar Road, and this road is very close to the hospital where I work. Uh, these are four pictures at four seasons, and nowadays, where when in winters the Chinar Road looks like this. Congo virus belongs to the genus of Nairovirus. The family is Boniaviridae. It is an RNA virus. It is spherical in shape, approximately 90 to 100 nanometer in diameter. It has got a lipid envelope studded with spikes of two glycoproteins, GN and GC, and then a genome which is segmented into three pieces, small, medium, and large, each encapsulated by the nucleoprotein and RNA-dependent RNA polymerase. Um, mm, Congo virus causes infection in humans and domestic animals like cow, goats, and sheep, and other mammals like hares and hedgehogs, but only causes disease in humans. The Congo virus is found in Africa, Asia, Middle East, Eastern, and Southwestern parts of the Europe. It has got the widest geographical distribution of tick-borne diseases, which is relevant to human health. The reservoir hosts are hares and birds and Hyloma ticks, and amplifying hosts are domestic animals like sheep, goat, and cattle. Humans which are at risk are shepherds, butchers, animal handlers, tick handlers, agriculture workers, veterinarians, health workers, and those people who are khana badosh, who are migrating along with their animals to different parts of the country. There are two main ways by which humans become infected with Crimean-Congo hemorrhagic fever. One is by tick bites. The cause of most human infections is tick bites. When an infected tick bites, salivary glands are introduced into the host. The viral replication at the site of the bite may be followed by spread of the virus to other organs. And the second way by which humans are infected is direct contact with contaminated blood or tissues from infectious patients. Human to human, or sorry, human to human or uh, carcass meat human transmission can happen whenever there is direct contact with contaminated blood, secretions, organs, or other body fluids that is from infected animals or patients. Hospital acquired infections can happen if medical equipment is not properly sterilized, needles are reused, or medical supplies become contaminated. Ticks are interestingly both reservoirs and vectors of Crimean-Congo hemorrhagic fever. The virus can survive and remain viable in the tick as it transitions from larva to nymph to adult, and it is transmitted less efficiently by venereal transmission. Exuded ticks, particularly members of the Hyloma genus, are primary vector in the transmission to humans. So the reservoir, which is Hyloma ticks, and reservoirs are also domestic herds, flocks, and wildlife as well. Ticks are reservoirs and vectors for the virus, carrying it from wild to domestic animals and humans. In nature, the Crimean-Congo hemorrhagic fever virus life cycle involves the ticks and vertebrates, including numerous wild domestic animals such as cattle, goats, sheep, and hares. But interestingly, most animals don't show symptoms of the disease. The disease um, only shows symptoms in humans. First contact between the ticks and the host happens when the tick bites and feeds on the host. This process introduces salivary gland secretion into the host, and with it, when the tick is infected, and triggers the host reactions. Human infection is of two types, primary or secondary. Primary infection is by tick bite. 80 to 90% of the humans are infected through tick bite or direct contact with blood or infected ticks, or direct contact with blood, tissues, organs, or bodily secretions or infected wild animals and livestock. And then secondary infection is either human to human transmission or nosocomial transmission. Human to human transmission occurs when the subject becomes in direct contact with the blood, secretions, organs, or other bodily fluid of infected persons. Or nosocomial transmission, high nosocomial transmission risk occurs when providing direct patient care or handling dead bodies in transport to the morgue during autopsies and preparing the corpse for the funeral. Various studies indicate that seropositivity rates are similar between sexes and increase significantly with age. Behavior and economic activity patterns seem to be the more gender-based, elevate the risk of infection. These also include herding activities, sleeping outside during seasonal migrations, and treating, monitoring, or inspected infected animals. Genetic factors may also play an important role because the immune status of the host depends upon the genetic factors. Um, it may affect the release of cytokines, which play a major role in the disease progression and outcome. And so people with these factors may be more susceptible to contracting the more severe disease. Humans are the only species in which Crimean-Congo hemorrhagic fever is known to cause severe disease. Apart from humans, human hemorrhagic fever virus, which are being used for experimental purposes. So the Congo fever can be a mild to severe hemorrhagic disease. Statistics from outbreak of Pakistan suggest that 88% of the people infected will have subclinical symptoms. Only 1 in 8 will develop severe disease. The most important clinical feature is sudden onset of high-grade fever. It is accompanied by headache, weakness, muscular pain, vomiting, facial flushing, rashes, and GI bleeding. Um, the disease is divided into 4 phases: incubation, pre-hemorrhagic, hemorrhagic, and then convalescence phase. Uh, this shows the different phases of the disease. First of all, the incubation, which is about from 3 to 7 days, and this is the phase where the viremia develops, and then the patient enters into pre-hemorrhagic phase, which lasts to about 1 to 7 days. Some non-specific or generic symptoms of fever, headache, and vomiting occur in this phase. And then after 7 days, the patient enters in the hemorrhagic phase. Uh, this hemorrhagic phase lasts to about 2 to 3 days, and there's bleeding from multiple sides. And after the 10th day, the patient either dies or enters into convalescent phase. Um, from the incubation to about 7th day, when the pre-hemorrhagic phase lasts, uh, the disease is only detected, can be detected by the viral detection markers we'll discuss later on. And then after that, the immunological markers also start rising in the blood. So the incubation period depends upon the mode of transmission of the virus. Infection, if the infection is by tick bite, the incubation period is usually shorter. It is about 1 to 3 days, but can be up to 9 days. Mineralogical substances present in the tick saliva facilitate viral entry via endothelial cells, and this may be a factor in the shorter incubation period. When the contact is, if the disease is contracted via contact with infected blood or tissues, the incubation period is a bit longer. It is about 5 to 7 days with a maximum of 13 days. And then pre-hemorrhagic phase, it is characterized by generic or non-specific signs and symptoms of fever, myalgias, dizziness, neck pain, stiffness, backache, headache, sore eyes, and photophobia. Other possible symptoms may include nausea, vomiting, diarrhea, abdominal pain, sore eyes, sore throat early on, followed by sharp mood swings and confusion. After 2 to 4 days, the agitation may be replaced by sleepiness, depression, and lassitude, and the abdominal pain may be localized to the upper right quadrant with detectable hepatomegaly. These are fairly generic symptoms found in many other diseases, but the case history, particularly potential exposure history to animals or to a diseased person, can be used by clinicians in their differential diagnosis to order the specific diagnostic test of Crimean-Congo hemorrhagic fever. Then the hemorrhagic phase, which starts on day 3 to 5 or after onset of first symptoms. The initial manifestations of the hemorrhagic phase include conjunctivitis, petechial rash of the skin, mucous membrane. Other clinical signs include tachycardia and lymphadenopathy. The petechial rash may give way to ecchymosis, bleeding from the GI and urinary tract, splenomegaly, and hepatomegaly. There is usually evidence of hepatitis severely, and severely ill patients may experience rapid kidney deterioration or sudden liver failure or pulmonary failure after the 5th day of illness. So the complications usually arise after the 5th day of illness. In fatal cases, shock and multiple organ failures occur between 5 to 14 days after onset of symptoms. Nosocomial infections are observed to be less fatal than direct infection by tick bites. It is thought that this phenomena is due to the difference in initial viral dose, which is higher with tick bites as compared to nosocomial infections. This was the patient, a male patient who was diagnosed with Crimean-Congo hemorrhagic fever in 1969, um, showing the ecchymosis all over his back. And then the convalescent phase may last up to a year and can be marked by one or more complications of anorexia, hair loss, hearing loss, memory loss, polyneuritis, or complications as hemorrhagic shock and multi-organ failure, and some less common complications which we discussed previously, loss of memory, hair loss, mononeuritis, alveolar hemorrhage, secondary infections from other bacterial infections, intracerebral hemorrhage or compartment syndrome. Pregnant patients of CCHF have got a very high maternal and fetal and neonatal mortality due to hemorrhages. So the incubation period is about 3 to 7 days, a total range of 1 to 14 days, generally shorter after tick bite or needle stick injury as compared to the contact with patients or nosocomial infection. In survivor improvement is seen in about 9 to 10 days after symptom onset, and convalescent can last up to a year. Mortality rate vary widely in this disease. Um, Data from Pakistan shows that about there is 20 to 25% case fatality rate. In endemic countries, mortality ranges from 4 to 20%. The key factor in prognosis appears to include the quality and experience of healthcare professionals diagnosing and treating the patient, early diagnosis and treatment of the disease, early diagnosis and treatment of its fatal complications. So the early detection and diagnosis of Congo fever can greatly improve patient prognosis by facilitating early treatment. Furthermore, patients' demographics, clinical findings, and laboratory reports can assist in prediction of disease severity. Presence of diarrhea, like hematemesis, ecchymosis, gingival bleeding, melena, and somnolence are suggestively common in fatal cases. In fatal cases, the immune serum becomes overwhelmed with very high titers of the virus. The lack of antibody response and distinctly raised cytokine levels uh, contributes to the fatality of the patients. A study in South Africa found that no antibody response was detected in fatal cases, whereas survivors had detectable levels of IgM and IgG antibodies by day 7 to 9 of the illness. To control the infection, the result is elevated virus titers in the serum and more intense inflammatory and cytokine response. These are the independent predictors of mortality, which include presence of hemorrhage, particularly GI bleeding and hematuria, impaired consciousness, CNS involvement, diarrhea, splenomegaly, thrombocytopenia, leukocytosis, increased aspartate and alanine aminotransferase levels, and lactate dehydrogenase levels, decreased fibrinogen levels with a prolonged activated partial thromboplastin time. In addition, raised to power 7 copies per ml is also an important indicator for mortality. The two most important diagnostic tests for diagnosing this disease is, first of all, the PCR test. The PCR test is positive early on in the disease, whereas the antibody response by the antibody levels by ELISA is detectable. IgG or IgM antibody is detectable after the fourth or fifth day of illness. It is to be remembered that patients with fatal disease, as well as inpatients in the first few days of illness, do not usually develop measurable antibody response. And so the diagnosis of these individuals is achieved only by virus or RNA detection in blood or tissue samples. Other non-specific laboratory findings, which are very important in the management of the patients, and these include thrombocytopenia, leukopenia, hyperbilirubinemia with elevated transaminases, prolonged INR, prothrombin time, activated partial thromboplastin time. Anemia is observed in some cases. In the setting of multi-organ failure, there may be elevated blood urea nitrogen, creatine phosphokinase may also be present. Patients with DIC may have decreased fibrinogen levels and increased fibrin degradation products. These are the WHO case definitions. First of all, suspected case. The case should be suspected when there is sudden onset of illness with high-grade fever over 38.5 for more than 72 hours, less than 10 days, especially in Crimean-Congo hemorrhagic fever endemic area, and among those in contact with sheep or other livestock, like shepherds, butchers, and animal handlers. Fever is not responding to any antibiotics or antimalarial treatment. And then probable case, a suspected case with acute history of febrile illness 10 days or less, and thrombocytopenia less than 50,000, and any two of the following: petechial, purpuric rash, epistaxis, hematemesis, hemoptysis, hematochezia or melena, ecchymosis, gum bleeding, and other hemorrhagic symptoms, and no known predisposing host factors for hemorrhagic manifestations, like there should be no bleeding tendencies in the patient. And then confirmed case, a probable case with confirmation of presence of IgM and IgG antibodies to Crimean-Congo hemorrhagic fever virus in serum by ELISA, and or detection of nucleic acid in the specimen by reverse transcriptase PCR. Also, this is the course of the disease. First of all, the incubation period where the virus levels starts to increase, and then pre-hemorrhagic phase, which lasts from 1 to 7 days. In this phase, the disease can only be diagnosed with PCR. Platelet starts to decrease, WBC along with them, and aminotransferase level starts to increase in this phase. And the patient presents with generic symptoms of myalgias, fever, nausea, vomiting, and diarrhea. And then the patient enters into hemorrhagic phase. After the 7th day, the disease can be detected in this phase by these serological tests, IgM and IgG antibodies. There is bleeding from multiple sites. uh, Aminotransferases are still rising, platelets and WBCs are still falling. And then after the 10th day, either the patient dies or enters into convalescence phase. So death occurs in second week of illness, or the recovery, it again starts on 9 to 10 day of illness. Complication occurs after fifth day of illness of hepatitis, kidney deterioration, liver deterioration, respiratory failure, or DIC. The treatment is mainly supportive. Supportive therapy is mainstay of patient management. So intense monitoring is important to guide volume and blood complement replacement. Fluid electrolyte balances should be maintained. Blood products, when needed, should be promptly administered to the patient. And then the treatment of secondary infection is very important with antibiotics if there is an evidence of secondary bacterial infections. Um, Platelet concentrates, fresh frozen plasmas should be readily available when needed. So the only drug so far which has known to be effective in vitro, although its use is still controversial in the disease, is ribavirin. But something is better than nothing. So ribavirin should be promptly given these patients. The dose is 2-gram loading dose and 4-gram per day in divided doses, 8 hourly for 6 days, and then 2-gram per day in divided doses for 6 days. Pregnancy is a strict contraindication, and pregnancy should be avoided even after 6 months of using this drug because it is highly teratogenic drug. Um, and then the foremost thing is prevention. Prevention is, as they say, is always better than cure. Prevention should be at the level of hospital and healthcare facilities. And then the most important thing, public should be educated about the disease. So the measures should be adopted to reduce the risk of human to human transmission in hospitals and healthcare facilities. And then at the public level, measures should be adopted to reduce the risk of tick to human transmission and animal to human transmission. Biosafety is the key to avoid nosocomial infection. Um, Patients should be isolated and barrier nursing techniques should be adopted. And then standard infection control precautions should be observed with personal protective equipments, basic hair hygienes, safe injection practices, and safe sampling of the disease patients. Um, Patients should be isolated, barrier nursing techniques, isolation of probable and confirmed cases in separate rooms, and only designated medical staff should attend the patients. All medical and paramedical staff and attendants should wear proper PPE when entering and moving and exiting rooms. So doffing and donning should be educated to all the medical staff who are attending these patients. These techniques all of us have learned during the COVID era. So human to human transmission should be reduced by decontaminating all medical instruments and autoclaves before he reused. All surfaces should be decontaminated with liquid bleach. Household bleach is enough for the decontaminating the hospital surfaces. After the patient is discharged, room surfaces should be wiped down and liquid bleach to kill virus, and the room should be fumigated if risk of tick infection. After the patient is discharged, room surface should be wiped down with liquid bleach to kill virus, and room should be fumigated if risk of disinfection. Um, Personal protective equipments, um, which include disposable masks, gowns, disposable gloves, and goggles, should be worn by all of the healthcare providers who are attending the patients. Basic hand hygiene should be observed. Hands should be washed regularly after caring or visiting ill people. And safe injection practices should be observed by avoiding spills, breaks, injuries, and accidents during management of the patients. Needles should not be recapped but discarded in proper safety boxes. Safe sampling techniques should also be observed while drawing blood samples of the patients. Samples for laboratory testing should be properly collected, labeled, and decontaminated from outside with bleach and packed in triple container packing. Designated laboratory should be informed about the sample and should be transported to the designated laboratory with great caution, ensuring there would be no breakage or spills. Then safe burial practice is very important. These burial practices, again, we observed these burial practices in COVID era. Same goes with Crimean-Congo hemorrhagic fever. Thick and long viral yeah, rubber gloves or double pair of surgical gloves should be used for washing the body for burial. And dead body should be sprayed with 1:10 liquid bleach solution and then wrapped in binding sheets. Binding sheets should be sprayed with bleach solution. So all of these guidelines should be educated to the responsible persons who are taking care of the dead body. Transport vehicles should be disinfected and the clothings of the patients should be burned down. Tick control with the caricides is a realistic option for well-managed livestock production facilities. Animal dipping should can also be observed in insecticide solution. It is a recommendation. Public should avoid tick-infected areas when feasible, especially when ticks are active. And in Pakistan, it is the springs and the seasons of the fall. Um, to minimize the exposure, light colored clothing should be worn because on these light colored clothing, the ticks are easily visible. The shirts are tucked into the pants and pants are tucked into the socks. Um, the clothes should be regularly examined for the ticks, and skin should also be regularly examined. Tick repellents such as diethyltoluamide, which is applied on the skin, and permethrin solution, which is recommended to apply on the clothing. They should be used, and especially the person who work with livestock or other animals in the endemic areas should take practical measures to protect themselves, especially during slaughtering, butchering, and culling procedures in slaughterhouses or at home. And also agricultural workers and veterinarians. Again, they should be advised to use repellents on the skin. The DEET is a recommended repellent to be used on the skin and permethrin on the clothing. So wearing gloves and other protective clothing to prevent skin contact with infected tissues or blood is also recommended. Prophylaxis should be offered to contacts, and contacts, as defined by the WHO, are of two types. First of all, the contacts are those healthcare workers who experienced accidental needle stick injury or other accidents where blood or secretions of patients were in direct contact with open wounds or mucous membrane, like those surgeons who are operating on probable and confirmed cases. Um, they might experience blood spillage over open wound or exposed areas or eyes of the surgeon, needle pricks, or those house officers and lab technicians taking sample of the patient, or those ward boys or khalas emptying the NG tubes and Foley's or drainage bags. Um, in these contexts, the baseline blood studies should be sent directly after the accidents, like liver functions, renal functions, PTA, PTTs. Platelet count is very important. So complete blood count to demonstrate the leukopenia and thrombocytopenia. And ribavirin in prophylactic doses should be started straight away in these patients in consultation with a physician. The second type of contact is those people who are exposed to same animals as the patient, and then members of the patient's family or who were exposed to the patient, the healthcare workers who were exposed to the sick patients, that is, they're directly physically examining or treating the patients. In these contexts, these contacts are monitored for about 14 days because it is the maximum incubation period from the date of last contact with the patient or other source of infection. Temperature is an important thing. Temperature should be recorded at least twice daily. Baseline blood test should be done, and ribavirin should be started only when the patient when these contacts become genuinely sick, like they develop fever, temperature equal to more than 38.5 degrees centigrade, or headache and myalgia, which are the generic symptoms in the first few days of illness. Otherwise, ribavirin is not required in these patients. There is no point in testing the blood for CCHF confirmation during the first 14 days after contact unless they are genuinely sick. Other tests to confirm CCHF only when contacts get definitely sick during the monitoring period, that is, first 14 days from the direct contact with the patient. Um, and then the symptoms. If the symptoms occur, the blood should be sent for confirmation of the virus. After the 14-day observation period, one may consider testing the blood for contact of a contact for research purposes to confirm whether they did or did not undergo subclinical infection. If they develop antibodies, uh, this shows that they they were infected with the virus. There are currently, sadly, no approved vaccines or treatment for Crimean-Congo hemorrhagic fever. And yet, up to 40% of the people admitted to the hospital with the disease will eventually die with this disease. This is a very high mortality rate. There was an inactivated mouse brain derived vaccine which was developed and used on a small scale in Eastern Europe a few years ago, but it failed to protect against lethal disease. So it is not being used now. There is currently no safe and effective vaccine available for human use. But there are news. This paper was when the vaccine failed to confer protection against lethal disease. It is of 2016, but there is news now that Oxford University had started administering another. It has started another trial and they are administering first ever vaccine against Crimean-Congo hemorrhagic fever. Um, it is being administered to healthy volunteers between ages of 18 to 55 years in that area of Oxfordshire, with participants receiving 2 doses of the vaccines 12 weeks apart. Participants are being closely monitored for the next 12 months to understand how they respond to the vaccine and whether they make antibodies against the Crimean-Congo hemorrhagic virus or not. If they do, this would be the first step in creating a new vaccine against Crimean-Congo hemorrhagic fever, and a milestone in which it will be a milestone for pandemic preparedness. So, in the absence of vaccine, the only way to reduce infection in people is by raising awareness of the risk factors and educating people about the disease, about the measures that they can adopt to reduce exposure of the virus. This can be by pamphlets, by advertisement, social media. These types of pamphlets are being made and uh, being spread into the people. And then, very important thing, when the Eid al-Azha arrives, precautions for Eid al-Azha should be disseminated in the general population, buyers and sellers of animals, and those who are slaughtering. Um, Site of selling animals, it should not be in residential areas. Animals should be treated with the acaricides. Direct contact should be avoided, touching with bare hands with animals, and persons selling and slaughtering animals. Open spillage of blood of animals should be avoided over the floors, and proper disposable of non-usable materials, tissue materials of animals in plastic bags should be done. It should be promoted by the local governments. So these are the references from which this presentation was made: the WHO guidelines and CDC guidelines, and the local guidelines which are issued by National Institute of Health in Pakistan. This is a tick. It is on a pore of the finger. It is about the total length is about 5 millimeter, and this carries a deadly virus, which is the deadliest, which is one of the most deadliest of the diseases of the mankind. This small tick can cause uh, this much fatal disease. So this was all about today's presentation. Um, Over to
Bravo,
the
Jalal.
panelists now.
That was a lovely presentation, Dr. Mir Jalaluddin Saab. Very, very well presented.
Thank you,
Any
madam.
questions? Any questions? I'm not seeing any question in the chat box, but this lecture has been downloaded and it will be again uploaded on all the different channels, and all our students go back to these channels and do hear it. It will be on the PMA platform, the WMC platform, the AJK platform. So it is there and it remains in history. Dr. Saab, I have a question, and the question is that this little tick, is it called Pisu in your area in Hazara?
Well, it is the tick which is known to cause, known to transmit or carry this virus is a special hyloma tick. Uh, the khatmal which we find in our hospitals, it is very common. The khatmal, or in Hazara, in local Hindko language, it is called chad. These this chad is not particularly this tick, the hyloma species, but the matter of the fact is that these all chads, or the species of different ticks, they can carry virus from one patient to another. So the hyloma tick is specifically known to transmit and amplify the reproductive life cycle of the virus. But other ticks and other animals can carry virus from one species to other species. So the khatmals and pisus and chade, which are found in our hospitals, are also notorious to carry virus from one species to others.
That's very sad and it's very dangerous. And it gives us one message that one should observe cleanliness and sanitation and spray all the furnitures and chairs. Because I've heard patients even bring it in with their clothes, with their chadars that they carry.
Yes, that is right,
So
madam.
I hope to Allah Pak all of you remain safe. And then you mentioned something about the cytokine storm. So it was like that cytokine storm which has been observed in corona cases.
Exactly,
So you
madam. This is
deal
the
with
same
it
cytokine storm.
accordingly.
Sorry, this is the same cytokine storm which was observed in corona cases. That is the reason where the steroids are also being studied in this disease, as well as it was um, administered in the COVID patients. And cytokine and that steroids have got a remarkable effect on improvement of those patients in COVID people. But the steroids used in this Crimean-Congo hemorrhagic fever, they reduce the cytokine storm to some extent. They have a role in preventing or reducing the hematological complications of the disease. But the cytokine storm, which is observed in COVID patients, it is the same cytokine storm which is observed in these patients of Crimean-Congo hemorrhagic fever as well.
Uh, this lecture has put me off from having cattle in the house. I was thinking of a few goats and sheep just to have nice organic food and meat. But now I'll not go for it.
Madam, you can keep the goats and sheep in home, but proper acaricides and proper measures should be adopted to get rid of the ticks which are harvesting on these animals.
Okay, from this platform, I'm very, very thankful to you, Dr. Mir Jalaluddin Saab. It was a lovely lecture. I really, really enjoyed it. I
Thank you very
think
much.
Kaushik Bharti Saab has a question. Yes, Dr. Kaushik?
Yeah, first of all, I'd like to thank Dr. Mir Jalaluddin for this excellent lecture.
Thank you, sir.
Really, I had just one question, sort of thought actually. It's not related to clinical aspects, but more of molecular virology and epidemiology. So if we take a look at CCHF virus and for example and hemorrhage and Ebola virus, we'll see that both are single-stranded, both they're enveloped viruses and both cause hemorrhage. It's a cardinal feature. Yet the case fatality rate is widely different. Like Ebola can be as high as 90%, whereas CCHF virus around 40 or so. So what do you think could be the reason for this? Any ideas?
I do not know exactly about the difference in the fatality, but maybe it is because of the cytokine storm which they generate. The amount of inflammatory response which they generate is different among many these viral hemorrhagic fevers.
Okay.
Like we see in dengue fever, dengue is also very endemic in our areas, and it is mostly observed in this part of the world. So the cytokine storm, the inflammatory storm which they generate is different among different um, fevers. But I'm not sure about why there is difference in the fatality rate of these diseases.
Just want to ask one other thing. Professor Kundi was just talking about the this cytokine storm in COVID-19. Is the same pattern of cytokine there? Like IL-6 is more elevated in case of this also?
Yes, interleukins are elevated in this also. So
Okay.
the cytokine storm is the same as
Same.
it is observed in COVID patients.
Okay. Okay. Thank you so
Uh,
much.
Thank you, Mr. Parthi. Now I give the floor to Kaisar Sajjad Saab, who is the Secretary General of the PMA, for his vote of thanks to Dr. Mir Jalaluddin. Dr. Kaisar, you can switch on your mic. Okay, I don't know, maybe he didn't listen to me. Anyway, I want to thank you on behalf of the Pakistan Medical Association and on behalf of all the associations which are attached with us. Thank you for taking out time on a Sunday, Dr. Mir Jalaluddin, and I thank all the participants. Our great professor, Dr. Masood Ahmed, who is a pathologist with us, is here, and Dr. Reem Khan, Dr. Soha, and Dr. Atif Hussain, who's the professor of anatomy, is here with us, and there are many other people. Have a great weekend. Pakistan Zindabad. Thank you. Allah Hafiz.